Welcome to this episode of unRemarkable Labs. We're fortunate to have a rheumatologist from Washington University and many residents from Washington University in St. Louis. Our expert is Dr. Colin Diffie. I got that wrong. Diffie?
Oh, correct. Dead on correct.
And we'll be presenting a case to him in the near future. We have a number of residents who are helping us with this. So I'm going to ask them to introduce themselves and just say a word or two about themselves. Cosette?
Hi, I'm Cosette Champion. I'm one of the second-year internal medicine residents at Washington University. I'm still trying to decide what I'm doing with my career, but Dr. Diffie says rheumatology is still on the table, so maybe I'll be convinced tonight.
Natasha?
Hi, everyone. My name is Natasha. I am a second-year resident at UAB, interested in general internal medicine.
Mohit?
Hi, everyone. It's great to be back on unRemarkable Labs. My name is Mohit Harsh. I'm a current chief resident at WashU, and I will be a hospitalist at the end of my tenure as chief.
Julie?
Hi, I'm Julie England. I'm a second-year medicine resident at UAB and potentially interested in infectious disease.
And Eric?
Hey guys, I'm Eric Prado, one of the second years at WashU, interested in academic hospitalist in the future.
Excellent. So who's going to present?
I have a case for us today. So I will just go ahead and get started with a one-liner. We have a 41-year-old female presenting with shortness of breath and swelling, and a little bit more background about over the past kind of 1 to 3 months, she noticed some swelling in her face, as well as some weakness in her upper and lower extremities, and it's been progressive as she's noticed. So she's been gaining a little bit of weight. She says the weakness is pretty symmetrical and to the point where she's now bedbound, and she's having some shortness of breath as well. So I'll kind of stop there and let Dr. Centaur and Dr. Diffie kind of give their thoughts from the medicine and rheumatological perspectives.
Well, we're going to let Dr. Diffie. So let's say you're on the wards, Dr. Diffie, and they're presenting this patient to you, and obviously you're going to look at it through a rheumatological lens, although rheumatologists in my experience look at everything. But what captures your attention from this HPI thus far?
Well, yeah, no, this is actually a great case already, right out the gate. I mean, a patient who's bedbound from whatever process is going on is obviously a very concerning situation. The fact that she's kind of got this diffuse swelling also, I mean, there's a lot of rheumatologic causes of that, anything from nephrotic syndrome, from some sort of, renal disease, all the way onto our more exotic conditions like capillary leak syndrome and other kinds of obscure things. It seems like it's symmetric versus this being like a vasculitis or a venulitis that's kind of causing venous compression and SVC syndrome. This comorbid dyspnea, I mean, there's obviously a number of rheumatologic causes that could be occurring here. I guess my initial thought, my first concern would be whether there could be interstitial lung disease is a fairly common problem in our patient population, such as the interstitial lung disease you would see in association with an inflammatory myositis would certainly be a big consideration. But I think we'd probably need to do a little bit more digging, strength examinations and things like that to see exactly what's going on here.
Do the demographics help you some?
It's a 41-year-old female. I don't know that it entirely rules in or rules out anything. It's certainly a demographic that would be at high risk of any of our common conditions, but I don't think that, I think this is a pretty non-specific demographic on my end.
But I was just thinking if this is a 75-year-old man, we'd be thinking about a different subset of diseases if in terms of priorities. And we do have an excellent question from Julie. She wants to know whether or not the 1 to 3 month timeline influences you, especially in considering some type of interstitial lung disease?
I mean, absolutely. I would say it's a little fast for most interstitial lung diseases, but some of our conditions such as amyopathic dermatomyositis can be, which is a mouthful. I mean, it's a great diagnosis there. But sometimes that's associated with fairly rapidly progressive interstitial lung disease. You might also wonder about, some sort of congestive heart disease or myocarditis associated with with a systemic autoimmune condition.
Yeah, and Mohit has a really good question. When you hear, and it's different from when you see it, but when you hear about diffuse swelling on the face, are you thinking nephrotic syndrome because maybe that's including the orbits, or you also mentioned other things, and I assume lupus might be one of those things.
Yeah.
So really defining the swelling in the face might be helpful. That's sort of a non-specific description as best I can tell right now.
Yeah, I would agree. Kind of non-specific at present. I mean, I think that when I hear face swelling, the first thing that came to my mind was nephrotic syndrome, but just since that's kind of a buzzword association. But again, I think you'd probably want a little bit more objective data before you start making any kind of calls here.
Well, since this is unremarkable labs, and we're going to get to labs here in a second, let's see where we're going.
Okay.
Give us some more, Natasha.
Yeah, so I can give you a little bit more in terms of review of systems, since that usually is pretty important in rheumatology. She has had normal menstrual cycles up to this date. She has been very fatigued, has not been able to really carry out her activities of daily living. We've already kind of talked about her weakness, but she's had decreased mobility as well as some mood changes that could be consistent with depression, though she doesn't have a formal diagnosis. She has noticed some hair thinning. This says diffuse, but in her case, it was actually pretty patchy, as well as decreased appetite, orthopnea, and feeling sore all over.
How does that add for you?
Yeah. I oftentimes say that a rheumatologist is a review of systems biopsier. Like, we really like to delve into our review of systems to really kind of figure out what's going on with our patients. The patchy hair thinning is certainly a lot of these things are concerning for a connective tissue disease that's underlying all of this. Commonly, our conditions will cause patients to feel fatigued, some lassitude. Patchy hair thinning, kind of different from kind of global diffuse thinning, might be more suggestive of an underlying lupus or lupoid-like condition, as opposed to alopecia areata or just generalized hair thinning. The orthopnea and decreased appetite does make me wonder about some sort of cardiac involvement, and then the soreness all over. Probably need to delve into that. Is it inflammatory in its description? Is it more, exertional? Is it over her joints? Is it in between her joints as well? To kind of help dive into the specifics on that a little bit. But again, commonly seen in our rheumatologic conditions. And then weakness, again, might make you wonder about lupus, myositis, an overlap condition. But definitely starting to head in the right direction towards getting some answers.
So I want to reemphasize something that you said, because I really liked it, is that sometimes, and I've written it this way before, sometimes we get nouns, but we don't get the adjectives. And so sore all over is sort of like a noun, but what do we really mean by sore all over? And the fact that you would like to ask more questions about that, I think that's a good role modeling for all of us, that we need to do that. Like, patients say they have diarrhea, and what do you mean by diarrhea? I have a loose stool every morning. One. Okay, that's not diarrhea. So maybe some past medical history. Is this a new problem, an old problem? Let's get some of that stuff out of the way. And then before we get the physical exam, Colin, it'd be really nice for you to talk about how you think about the physical exam in a patient like this. But let's get the past medical history stuff first, social history, etc.
Okay.
Yes, so pretty unrevealing. She's actually never been to a doctor before. Says she has no health problems, is not on any medications. We asked specifically about supplements as well. No family history that she or her husband could recall, and she's never had surgery. In terms of her social history, she lives in Tennessee with her husband, doesn't use any alcohol, tobacco products, or recreational drugs. She is on her way back from the beach. So just a little bit more history. That's kind of how she ended up in Birmingham, Alabama. They had driven down to the beach. Her husband was hoping to improve her mood, and thinking that, if she gets a little bit of rest and relaxation, that she might start to feel a little better. And actually, in between the beach and on the way home, she ended up, she went to the bathroom at a diner, and she hadn't come out in a while. So her husband went to check out her and found her on the floor, kind of clutching the sink, unable to get up.
So, as a rheumatologist, the first thought that I have coming out of the gate here is like to reemphasize what you said, Dr. Centaur. Like whenever I hear this, I really would like to delve into the specifics. And, when I've got a patient, I try to spend, 45 minutes, an hour with them, really talking at length through all of their symptoms and the timeline of events. It sounds like she was actually doing okay while she was at the beach. And then it was on the trip back home where she had this decompensation. Is that right? Did I hear that correctly?
Yeah. Mm-hmm.
And that's important in my field because really prominently in myositis and in lupus, people are very photosensitive. And you can kind of really delve into the specifics here because some people might kind of conflate photosensitivity with heat sensitivity. And so questions like what happens when you go out on a hot day? What happens when you go out and there's cloud cover, which might block UV light? What happens when you're driving in a car with temperature control, but with the windows kind of letting sunlight come through so that you can kind of see whether it's more response to UV radiation that's kind of stimulating their immune system, as opposed to whether it's more just sort of heat sensitivity and lassitude from that. It sounds like in this situation, really the beach would be the worst place for photosensitivity. And it seems like she was doing well there and then everything kind of got worse actually on the trip back home. So a little atypical, but I wouldn't hang my hat on that necessarily.
And just to follow up on what I said before, as you're approaching the physical exam here, and I'm always impressed with the physical exam that rheumatologists do, what are going to be the key things that you're going to be focusing on from this story? Obviously, you may find things that are not clued in here, but how do you think about doing the physical exam?
Yeah, no, I think one of the nice things about being a rheumatologist is that you really do have to focus on everything to a degree, but the things that I think would really be salient here, given the shortness of breath as a chief complaint, would be a good cardiopulmonary examination. Are you hearing an S3 to imply some sort of congestive heart failure? Are you hearing crackles in the lung bases, more kind of dry Velcro, like changes that you might hear with interstitial lung disease? On strength testing, there are a vast number of myositic conditions beyond just dermatomyositis and polymyositis. But as a rheumatologist, I, of course, would be especially geared into those. So looking for particularly weakness with proximal muscles, in particular deltoids, biceps, and then hip flexors tend to be the most commonly affected in an inflammatory myositis, maybe checking to see whether they have weakness with their sternocleidomastoid, whether it's more of a kind of diffuse global weakness, where they have weakness even with like pushing their head forward. A very careful examination for a rash, which oftentimes can be the clue to kind of gear you towards one of our conditions. So, looking carefully for any kind of inflammatory changes on the eyelids, a shawl sign, a holster sign on either side here, that might kind of point towards an inflammatory myositis versus more of a malar rash from lupus, which might classically spare the nasolabial folds, which are sun-protected areas of the face. And so, and then looking at her joints, I mean, she's complaining of being sore all over. And the nice thing about MSK is oftentimes all you need to know is, your anatomy and then add the word itis, right? So if they hurt over a joint, it's arthritis. If they hurt over the epicondyle, it's epicondylitis. And so a very careful examination for synovitis can be helpful in these situations. If you see frank synovitis, it implies a much more inflammatory joint process, maybe in the rheumatoid arthritis realm versus more just sort of feeling achy the way a lot of people with lupus might feel achy, versus more kind of muscle-centric pain, the way you might see in a myopathy of some sort, and or fibromyalgia as a common thing, and trying to delve through some of these issues.
Okay, let's get some physical exam and then we'll figure out what to order.
Sounds good. So she is afebrile, tachycardic to the 140s, normotensive, and initially when she comes in, she's satting 98% on 2 liters of oxygen. In general, she's alert and oriented. I would say probably mild to moderately distressed. She has, you can see right off the bat that she has periorbital edema with patchy hair loss. Her JVD is at the level of the jaw with her kind of reclined at about 45 degrees. She's tachypnic. She has rhonchi, as well as wet crackles heard in bilateral lung fields, and breath sounds are decreased bilaterally. We already talked about her tachycardia. She also has 3+ pitting edema in her lower extremities and all dependent areas. And then her gastrointestinal exam is pretty unremarkable. In terms of her MSK exam, I had strength to gravity, but it seemed like she was too exhausted to put in the effort, really, to where we ended up repeating the exam the next day. And our neurology colleagues came by and they said she was closer to 4 out of 5 when they were able to have her put in the effort. Her extremities were cool to the touch. No rashes that we appreciated. She did just appear a little bit flushed in general, but no rashes anywhere. And at the time of initial presentation, she was alert, oriented, and talking to us. She was Mandarin speaking only, so it was through a translator. Excuse me, the ED, her husband, was serving as a translator because we did not have the iPad. And she could speak in English a little bit as well.
What about joints? Did she have any joint pain?
So not specifically. It almost seemed like she was tender because of the swelling and the fluid more so than just over her joint. She was tender in her joints, but she was also tender everywhere else.
And Mohit was really interested in if you were thinking about Raynaud's, what physical diagnosis maneuvers do you use for that column?
Definitely, yeah. So for Raynaud's, what I like to do is called Nelfold capillaroscopy. And so essentially, it's best with, obviously, the best kind of like dermatoscopes are going to be a little bit better than your naked eye, which is not going to be an effective way to do capillaroscopy. They're going to be better than just about anything to use a dermatoscope. But you can actually just buy a fairly inexpensive jeweler's lens off of Amazon for $6 or $7. That's actually what I did for my initial fellowship. And then you just zoom in very closely right to the Nelfold bed, right immediately proximal to the cuticle, or the fingernail itself, I should say. And normally, whenever you look at a healthy person, you can see kind of these undulating capillaries in that area. But when people have Raynaud's from a primary condition, just sort of they have Raynaud's, which is a fairly common finding, especially in a 41-year-old woman, you might still see normal Nelfold capillaroscopy. But if you're looking for a more kind of systemic autoimmune cause of this, you oftentimes see capillary loop dropout, hemorrhage, aneurysm. So like kind of changes actually in the capillaries whenever it's more related to a systemic autoimmune condition. And it looks like you're also asking about some MSK point of care ultrasound things that we can do in order to help tease this apart. I think for this particular patient, MSK ultrasound probably wouldn't be as pertinent if it's more kind of just diffuse pain wherever you see edema. You can see edema on an ultrasound. It's actually pretty cool looking. I think I'd be more interested, if anything, in heart ultrasound in this patient, but I think it can be very helpful whenever you're trying to look at for a autoimmune cause of pain. You can see very clearly with modern technology whether someone has synovitis with much greater sensitivity than you'll ever be able to do with your fingers, which are only about 70% sensitive for synovitis. You can also see whether it might be some other structure, such as the tendon sheath that's actually causing their pain, or they might have tendinitis or tenosynovitis or enthesitis. And so I think it's an extension of your physical examination with modern usage of point of care ultrasound. And whenever I have a patient where there's any question at all of what's going on, I find it to be the most helpful modality to really visualize whatever is actually going on. And it's highly sensitive, highly specific, trainable, teachable. Anyone can do it if you put a little work in at it.
So this patient clearly is inflamed. Cosette just typed in, as I was getting ready to say, that heart rate of 140 gets our attention really quickly, and the blood pressure's high, but yet the extremities are cool to the touch. That's sort of interesting. Let's put all that together, and from a rheumatological point of view, what are you looking for in the routine labs before you start ordering more specific labs? So what would be someone like this comes to your office or comes to my office, what are the initial tests you're going to get, and how might that instigate what you get afterwards?
So basic labs like, CBC, CMP kind of issues, or kind of delving more into the room lab.
And what are you focusing in on those? And would you be getting a SED rate and a CRP in this patient? Would you already be ordering some rheumatological studies? You're waiting for some other things to come back?
I think there's a number of labs that would be really helpful. A CBC, I mean, this is a patient where we suspect some sort of systemic autoimmune condition based off of some of what she said, and based off the fact that you're telling this to a rheumatologist as well. I would say things you'd wonder about would be like, does she have any cytopenias? Does she have bicytopenia, pancytopenia? Does she have an isolated neutropenia, something that might be suggestive of a rheumatologic possible kind of issue that she's dealing with? Or hemolytic anemia would be another thing that we could see with lupus in particular. On a CMP, I would wonder about her creatinine, of course, and her BUN. And of course, whenever you see someone who's kind of has some concern for, cardiogenic changes here, you'd wonder about their sodium in that situation in particular. But other things that you might look for, if we're concerned at all about the possibility of a myositis on a CMP, you can see an AST greater than ALT elevation as that enzyme gets leaked out of muscles. I think of that in alcoholism when I see that pattern. You can also see I'd probably check I would check an ESR and a CRP, of course. I'd check a CK and an aldolase, with the aldolase being less specific for muscle changes, but you don't want to overlook a potential clue. And then I think I'd probably, realistically, rheumatologic labs take several days to run, 24 to 72 hours, some of them 3-4 weeks. And so I think I'd like to see the initial workup myself before I start kind of wasting everyone's time and money with everything else. But, you can see this patient probably in their future will have an ANA, an ENA, a dsDNA, and a myositis panel somewhere down the line.
Unless something else shows up. And
a UA, I should say.
The UA, to me, once you have periorbital edema and hypertension, you're getting a UA. And on the CMP, we'll probably get an albumin, and that might be a good clue. And the total protein albumin combination sometimes gives us clues.
Yeah. And, oftentimes we think in general medicine of like a protein albumin gap as a sign of myeloma, but any antibody will give you a large protein albumin gap. So if that's gigantic, you'd check an SPEP, but if that came back normal, you'd wonder, oh, is this because they have a high titer ANA or some other antibody?
Okay, let's see what we can do with the routine stuff.
Yes, and I'll give you a bedside ultrasound as well, just because that's something I've incorporated into my physical exam. I didn't put it on here just because I ran out of space, but she did have a mildly reduced EF, about 35 to 40%, as well as a pericardial effusion. It was small without any tamponade physiology. She had bilateral pleural effusions as well. I unfortunately do not have the expertise to do any joint ultrasound, so I will not be able to provide that. In terms of her basic labs, so for her BMP, I didn't highlight the abnormalities, but she has a low bicarb of 18, BUN and creatinine are both elevated. And then in terms of her CBC, she has an anemia and a thrombocytopenia.
Okay.
So
Still a bicytopenia.
yeah, so this is not surprising, but from a rheumatological point of view, how do you interpret this information going forward? And is this causing you to start ordering things?
I think I'd probably wonder about a blood gas, and someone who seems to be dropping their bicarb a little bit would be a consideration. And with a new O2 requirement, I think those are both really good reasons to wonder about their acid-base status.
Okay, I'm going to be obnoxious here and say we don't know she has an O2 requirement. We only know that she was on 2 liters.
Oh, okay. Sorry about that. Fair enough.
Okay,
I hope I didn't
apologize
step on a
for that,
landmine there or something.
I did a podcast called "Beware the Oxygen Fairy," and so, but this is a really interesting point. That bicarb of 18 could be from the kidney, but it could be from hyperventilation. This could be secondary to hyperventilation. The question is, first, I'd take her off the oxygen and see if she really needed oxygen, but might a VBG be just as good, just to figure out where it goes? And a lot of times I'll just get a VBG in that situation. But there's clearly some kidney disease. That's really pretty amazing. So how do you put together the bicytopenia and the inflammatory process? And it looks like there's kidney disease. We have the physical exam that's making us think of nephrotic syndrome. You thought of that immediately, that came to your mind. And once you think about nephrotic syndrome, you're thinking about all kinds of your specialty combinations. And I think what we're trying to figure out now is it just the kidney, or is it the kidney and the lungs? Is it a renal pulmonary, something like that? So
yeah. That's yeah, absolutely. So, with this bicytopenia, there is what we call, there's Evans syndrome, right? Which you might wonder about, like, is this a hemolytic anemia along with a thrombocyte destroying process of some sort, or is it sequestering into the patient's spleen and, secondary to everything else that's going on systemically with this patient would also be a consideration. And so probably at some point I would get a spleen ultrasound too. With these kidney labs though, they definitely stand out to you. And so I would definitely want to get a urine protein to creatinine ratio. I would want to get a urinalysis. At some point I'd probably want to check a lipid panel, although I don't think you'd be able to do that while they're in the ER realistically.
Let me go ahead and try to answer Mohit's question. So we were thinking nephrotic syndrome, and nephrotic syndrome, many nephrotic syndromes present with normal creatinines. This is an elevated creatinine, which means that we may well be dealing with glomerulonephritis, where you have both nephrotic and nephritic components. And I think that's what we're worried about right now. And that fits much more into the rheumatological realm. Would you agree, Colin?
Absolutely, sir. I think I would worry about that. I'd probably have a very enterprising medical student collect their urine and then go down and spin the urine with them and take a look and see if you could see dysmorphic RBCs. I would probably, the patient does have normal blood pressure, but again, it kind of does make you wonder about, I mean, just to kind of put some features of this patient together, multiple areas of serositis, this kind of bicytopenia. These are definitely things that make me think as a rheumatologist of lupus in particular.
Yeah, and Julie wanted to know about Evans syndrome because you never know, it might be on some board question.
Yeah, and I don't know that
we
I've
just
got
don't remember what it is.
yeah, and I don't know that I can cite a chapter and verse definition of it. I think that it's whenever you have the presence of multiple autoimmune cytopenias, there may be some additional criteria to it that I'm not entirely familiar with. But it's commonly like a hemolytic anemia and then an autoimmune neutropenia or an autoimmune thrombocytopenia. The platelet count is a little bit high for an autoimmune thrombocytopenia, where you might think of it as being more in the ITP range, but never say never.
Okay, a few more labs.
Yes, I think I have things you want. Okay.
Okay, there's your protein tab,
Yeah.
and there's your AST to ALT.
Hey.
You predicted like all these things.
Y'all have already sent this to me. I know it. No, I'm joking. But yeah, so I mean, I think I would definitely want to check an SPEP in this patient with that protein albumin gap. In addition to the presence of things like paraneoplastic syndromes, patients with an underlying rheumatologic disease are at much higher rates of hematologic malignancies. So you'd want to make sure they didn't have a secondary, paraproteinemia. Dollars to donuts, though, it's probably just related to having a high titer antibody in this patient. That AST to ALT ratio, a little bit underwhelming CK, I would say, for that to be the entirety of the story there for that ratio. That's kind of on the low side, I would say, of only 201. Patient seems to be having a lactic acidosis, so they're failing to perfuse their tissue well, and their BNP is fairly elevated, I would assume, on this assay here, kind of which points again towards this heart process here. And as you pointed out before, they have cool extremities in this situation. So you would wonder whether there may be a relative hypotension in this patient, if that might have not been really perceived before, or if there is any other mesenteric ischemia or any other number of areas that are being, ischemic in this situation.
Let me ask you about arteritis versus vasculitis.
Okay.
Because if it's an arteritis, that might lead to the cool extremities.
Yeah.
And is there a way for us to think about that as in our differential somewhere?
Well, my area of focus and interest is in vasculitis, and so I'm really glad you brought up my favorite topic. The kind of striking thing in this situation is that it is all four limbs. That would be a little bit hard to explain on the basis of an isolated lesion unless it were very proximal on the aorta. And so, I mean, you would wonder about that possibility, but I think as far as differentiating arteritis and vasculitis, I think the terms, someone's gonna, write hate mail in a comment section somewhere online for this, but the terms are oftentimes relatively interchangeable. Most forms of vasculitis are a primarily arterial disease. There are some, such as Behçet's disease, which can affect more of a venous circulation as well as an arterial circulation. But in general, anything that inflames an artery is a vasculitis, and vasculitis is just sort of kind of like all squares are rectangles, but not all rectangles are squares. I think that it's something that you would probably consider in this patient. I could see an ANCA being something that we would recommend here, given the concern for glomerulonephritis. But usually these kinds of small vessel vasculitides that are going to affect a patient's kidney will not lead to like a large vessel change that will actually affect perfusion of one of their limbs. And so probably it's not going to wind up being that.
So the urinalysis is certainly consistent with the glomerulonephritis, and I love the idea. At our institution, we'd call renal, and they'd get some warm urine and go look at it. But the idea of actually going looking at it with the intern or the medical student and looking for dysmorphic red cells, looking for casts, but we certainly are playing around with the idea of glomerulonephritis with both blood, assuming that she's not on her period.
Yeah.
Assuming she's not on her period, that much blood and that protein creatinine ratio. What's our urgency in figuring out what a glomerulonephritis is?
I would say, fairly urgent. We don't really know where she is in the overall trajectory of things here. And patients with GNs do frequently have their kidneys just tank. And you don't want to sit around for 3 weeks as an outpatient letting that happen while you try to figure out what's going on. This is someone that I would admit to the hospital if they came to me in clinic, probably for an expedited workup and evaluate, at least pre-COVID. I mean, the fundamentals might be a little bit different here, but I think this is someone that you would go very aggressively in order to figure out. Thankfully, we have really great colleagues in renal that I would probably be getting very promptly involved for consideration of a biopsy here, assuming that the rest of the workup doesn't give a very clear answer.
Do you really need a SID rate and a CRP in this patient, or can you just go straight to ANA, ANCAs, etc.? I mean, we know there's an inflammatory process. We don't have to prove that it's an inflammatory process, or is that likely to change how you think about the patient?
I don't think it's going to change how I think about the patient now, but it might change how I think about them 6 months down the line. Okay. So whenever I see them in clinic, I'd like to have that good baseline inflammatory marker to say which inflammatory marker trends with their disease. And then 6 months down the line, they say, I'm feeling a little bit under the weather. Is this my autoimmune disease? Is it not? You like to have that trend for that purpose. So I would, but I don't think I would wait around on it. I think I'd probably, get the ball rolling.
Okay, so I'm going to ask you to predict what the labs are going to show. So this is just what fits the best.
I mean, if you see a pericardial effusion and a pleural effusion, you have multiple areas of serositis in this patient. No belly distension. You have patchy hair loss. You have some kind of prominent constitutional symptoms. You have this large protein albumin gap, glomerulonephritis, lupus, I would say. And so I would probably expect them to have at least an ANA in the 1,000 plus range. I would, given, that this is pretty severe lupus. Not necessarily, I mean, sometimes it could be lower, but, when you're dealing with real deal lupus, you expect those higher titers. Probably if they have renal involvement, you might expect with some degree of accuracy, a dsDNA to be positive, a Smith antibody to be positive. And so I definitely would wonder about their extractable nuclear antigen and their dsDNA too.
And if Mohit is working as a hospitalist next year and this patient's admitted to him, should he start steroids right away while he's waiting for all the other tests to be done because of the severe inflammatory process?
Yeah, well, as a rheumatologist, whenever I see a patient like this, I'm trying to piece the puzzle together right out the gate, and labs are oftentimes things that take time. I think in this case, the labs probably would be back in within 24 hours, but I don't see a lot that really makes me concerned about an infection or something that's really going to get a lot worse here. I think that I'd probably talk with the patient really frankly and say, hey, I'm really concerned this is what's going on. We can wait a couple of days to get lab results back, but I think it'd be better to just go after this and not let things get worse, because these patients really can crump and you don't want to wait around on that when you've got a really high index of suspicion. So I probably would go ahead and pulse this patient and start getting the biopsy and let all that stuff sort of fall out as it may. But I think I'd pulse the patient here.
Okay, let's show us what happened, Natasha.
Okay, so there was a little bit of unintentional dishonesty. So this blood pressure was actually after she was given some IV labetalol, which we found out later. So she had come in the basically 200s over 100s. When cardiology was consulted in the ED with her respiratory status, her BNP, and their ultrasound, which was obviously more precise than mine, showed a slightly lower EF. And with her lactic acidosis, cool extremity, she actually got admitted to the CCU for cardiogenic shock and was started on a nitro drip. And so her hospital course then was, you know, she didn't have a general medicine team necessarily. She did have residents taking care of her, but it was the cardiology team that was in charge. And so at first, the first 2 labs autoimmune to come back, let's see, were her ANA, which was pretty strongly positive, not quite in the thousands, but her anti-Smith was negative. So initially the cardiology team was not part, there was factions of the team. So I was saying, myself and my fellow were saying, hey, we probably need to call renal and room, like this looks like lupus, it smells like lupus. The attending wasn't completely convinced. He said, she has a negative anti-Smith. So they were working on her cardiac stuff for a couple of days, trying to optimize her from that standpoint, trying to aggressively diurese her. And then when the double-stranded DNA came back, then the entire team at that point was convinced that, okay, this is probably lupus. We should probably call the rheumatologist. We should probably call the nephrologist. And just to clarify, we kind of already talked about her chest x-ray we talked about her ultrasound, but just to clarify on the weakness, she actually didn't have myositis. She ended up getting an MRI that showed transverse myelitis. Neurology was consulted. She ended up getting pretty sick. As you said, you know, unfortunately her care was delayed a little bit with rheumatology and nephrology not being called immediately. And so she ended up decompensating. Her kidney function continued to worsen to where she ended up on CRRT. She ended up rheumatology. As soon as they saw her, we're also convinced it was lupus. She got a ton of immunosuppression. I did not write down everything. I think my husband saying in the background cyclophosphamide and rituximab at first, plus steroids, and eventually ended up developing her thrombocytopenia aggressively worsened, her kidney function worsened, and she ended up developing TMA as well. And her course was complicated. She was hospitalized for months with various infections, did end up getting discharged to rehab, but you hit the nail on the head kind of from the beginning.
So first of all, great job, Colin. I'd like each of the residents to share, to wrap this case up, the most important thing that they want to take home from this. And we'll start at the bottom of my list and work my way up. So Eric, you get to go first.
So I think for me, the most important thing is to keep an open mind. Initially, I wasn't thinking, actually, I was kind of anchoring on heart and cardiac, some kind of new heart failure going on. And I was interested immediately in an ultrasound, but to kind of take a step back and look at all the labs, I think it's important to factor in the muscle issues as well. So again, the biggest thing is to kind of keep a broad mind and prevent anchoring too soon.
Julie?
Eric, you stole mine. I was actually going to say the same thing. You know, when I saw the patient like that in the ED, I wanted the bedside echo. I wanted to admit them to CCU. I probably would have admitted them to CCU still. And then you kind of have a tendency to blame your lab abnormalities on your initial diagnosis. Like, well, maybe they've got some cardiorenal syndrome causing the elevated creatinine. Maybe they've got some congestive hepatopathy causing the elevated liver enzymes. So Natasha's first take-home point, keeping a broad differential on a subspecialty service, I think is really important, because when you're seeing the same cardiac thing every day, you have to take a step back and remember the other systems that are important to think about. So that's my big takeaway point too.
This is what always scares me about subspecialty services. But spoken as a generalist, obviously. Cassette?
I agree with all of those points from before. It would have been really easy to anchor on this one. I thought it was notable how kind of quickly she decompensated. I easily could have seen a patient coming in with, maybe what happened earlier in her presentation, a little bit of lower extremity swelling coming into the primary care clinic. And like, how often do we see that in our clinic? But then just seeing like how rapidly she progressed and how very sick she got very quickly. Really does encourage you to keep that high index of suspicion of how you'd want to work this up really, really quickly.
Yeah, I think the point that Colin made, and I'm going to ask Colin to comment now, that glomerulonephritis, when you see acute glomerulonephritis, be very scared because it often is accelerating because she hadn't been sick that long. You see more of it than I do, Colin.
Yeah. And TMA actually, very classically associated with lupus is a relatively common cause, I should say, of it, at least for me as a rheumatologist. But whenever I see anyone who has renal involvement, be it from encapsulitis or from lupus, these patients just really can't decompensate from it. And when damage occurs, you can't undo it later on, right? You might get some improvement, but usually it won't, return back to normal. And so time is kidney here.
Mohit, you've been doing a lot of teaching of clinical reasoning, I know. From that standpoint, what are your big takeaways for how you're going to be teaching about this?
I think it goes back to what you mentioned earlier, that we sometimes just get the nouns. We need the adjectives as well. I think that is obviously very important in rheumatologic conditions, but I think that same sentiment can be stated for every specialty, both within internal medicine and outside of internal medicine. We are often taking on a lot of patients, have a lot of volume to manage, and it can be very challenging to get those details in the moment, but the history doesn't have to stop with the initial encounter. It can happen later on when you have some downtime in your call day. It can happen the next day in post-call when you've had time to think about the patient. So always taking the opportunity to reflect on the case and saying, what doesn't fit, what does fit, and what more details do I need in order to help advance the care of this patient.
So I'm going to also frame this in another way. This is building on what everybody else said. 41-year-old women who have no past medical history rarely come in with severe hypertension and heart failure. And so the first thing I would ask is, wait just a second, this doesn't make sense. Why does all of a sudden this woman have this? And actually think of a differential. Now, that's easy for me to say because I'm a generalist, but I actually do that. Natasha's round with me, and I really do that all the time. And so the story in many ways from a clinical reasoning aspect is scary. But I think we've learned a lot. Colin, you get the last word on this, and then we'll do a quickie.
Yeah, no, I think that's a really great point. You should always ask, is this normal? And it's not clearly normal in this situation. To quickly answer Cassette's question, I always try to check as many things as I can up front. And then at some point when the patients are doing well, and then figure out what actually trends with their disease activity. So I didn't mention complements, but like there are such things as complement copy number variations where some patients just have fewer copies of the gene that encodes for complement. And so they're always going to have a low complement. And so you don't always know which one's going to trend with disease activity when you first meet someone. So I just test broadly, honestly. And then I think to echo everyone else's point, the hardest thing in rheumatology is just thinking of it, right? Because it's not something you see every day. It's a minority of patients. And so keeping that in your mind, whenever you've ruled everything else out, well, could this be something rheumatologic? Then getting us involved at that point.
Well, I think this has been great. Any last thoughts, Natasha? Because and thank you for bringing this case, because I think it brought up so many interesting questions about history taking, physical exam, how to interpret labs, how not to ignore abnormal labs. That I think it's going to be very useful to anybody who watches this or listens to this in the future.
Yeah, so this was this is my favorite case in residency and my medical career so far, just because it's been the case that keeps on giving. I've learned so much. So I initially admitted this patient and took care of her for an entire month. I admitted her on night float in the CCU, and like Julie said, it is really easy to anchor. And my fellow was actually a second-year fellow who graduated from our internal medicine residency program, and he and I together, kind of as we were on nights during the week, pieced together that she probably had lupus, and he actually thought of TMA. So I think that being a good subspecialist also entails being a good internist, because you don't want to miss what's really going on. Her heart failure was probably just a symptom of her raging lupus. So I really enjoyed this case. I learned a lot about thrombotic microangiopathy. It's something I hadn't really thought of since medical school. And I think, you know, this case just provides a lot of learning, and it was only supposed to be 30 minutes and we took almost the whole hour because we just had so much to learn from it. So I think it's just really a great case, and hopefully everyone will learn as much as I did.
It's an hour well spent.
I completely agree. And this is my second time presenting this case, and I've learned more and more. And I just want to thank you, Dr. Diffie, for especially in asking lupus patients about sunlight versus heat. That's not something I'd really thought about, or if for someone if we're concerned that they could have lupus. So, and I also really appreciated your point, Dr. Centaur, about the adjectives and not the nouns, and Mohit, what you were saying about going back the next day, which is actually what we did with her. And her husband made some calls and ended up telling us the second day that, oh yeah, by the way, her aunt has lupus as well, something that didn't come up the first time, but they called the family to ask if anyone had any other problems. And so I think it never hurts to go back and ask more questions. So I think on that note, we will end for the night.